Okay, so Sunday, February 25th, just after 10 a.m. We're going to attempt potentially the longest, most epic Anki marathon of my PA school career. So the idea here is, so we have an exam on Wednesday. It's a beast. It's the first one on endocrinology. Not really sure what to expect here. We have 7 PowerPoints to get through. My goal for this session is to get through the first 4. The first one is Intro to Endocrinology. The following 3 are all on diabetes. So we're just going to get straight into it. If I can complete this today, it will be a personal record in terms of Anki. So I don't know. I don't have anything else to say. We're just going to dive right into it. Let's do Intro to Endocrinology. Okay. Man, this sucks. Bluetooth. We are connected. Joy key. All right. Oh man, this is the worst. Okay, we're gonna have some fun. Hormones are usually bound to blank proteins, plasma proteins. Let's go, baby. Part of the epithalamus secretes melatonin. That's going to be the pineal gland. Secretes melatonin, not melanin, regulates sleep patterns. All right, let's make this a little bit larger. There we go. Let's go away. Over there, maybe. The adrenocorticotropic anterior pituitary, what kind of cells? Corticotroph cells. Let's go. Follicular stimulating hormone. This comes from gonadotroph. I cheated there. Ovaries. Estrogen. Inhibin B. Is progesterone there? It sure is. Oxytocin, birth, emotion, and orgasm will upregulate oxytocin. Fasting. What's going to stimulate growth hormone? Probably not starving. I'm not sure. Is this ketosis? Ghrelin. Okay. Anterior to prolactin targets breast tissue. Testes for, this is spermatogenesis that lives with FSH. Anterior pituitary, this is going to be those gonadotroph cells. Hypovolemia and nausea, what's going to bring in vasopressin? I don't know. Mannitol, okay. Elevated testosterone, elevated estrogen, blank from Sertoli cells. Inhibin, okay, we'll pause FSH or downregulate it. How does the pituitary get all of its hormones all over the body? Through pituitary. Just venous drainage. Yeah, into the cavernous sinuses and the internal jugular. Okay. Oxytocin is produced where? Produced in the hypothalamus, but then it's moved to, oh, wait. I'm sorry, hold on. Yes, produced in the hypothalamus, then it moves to the posterior pituitary. Parathyroid regulates calcium and phosphorus. Kidney is going to be EPO and renin. Let's go, baby. All right. TSH, what's going to upregulate, downregulate? Upregulate should be T3, downregulate. Okay. All right. Low T3 is going to stimulate TSH. Hey, we need more if that's the active one, right? Elevated T3, it can cut it off. That's enough. Big thing about TSH is that there's no hypothalamic inhibitor. There's no hypothalamic inhibitor for adrenocorticotropic hormone as well. I think that's important. Nor is there for prolactin. And that's what this question is. So TSH and ACTH, I just forgot to put it in for ACTH, no hypothalamic inhibitor. Good. Intestines. Okay, so this spells CIG. I is incretin, G is ghrelin, C is cytokines. Let's go. Negative. All right, positive feedback loop. That's all about augmentation. A big thing here is childbirth, blood clotting. It's when we get a little bit of a stimulus and the body's like, let's keep doing that. Let's keep going. Second one here, lutein, so luteinizing hormone. Adrenal glands, medulla. This is going to be, yeah, so it's like MEN, men. It's epinephrine, norepinephrine. Is there a third one here? Dopamine? Just the 2, okay. Growth hormone, blank, stress, trauma, sleep. Okay, so sleep upregulates growth hormone, probably because of hypoglycemia, I would assume. Thyroid, that's whatever. Thyroid stimulating hormone lives on the upper right. This is going to be growth hormone. This is going to be regulated by what? Just gonadotroph releasing hormone from the hypothalamus. Oxytocin does what for uterine contraction? The uterus? Okay. And mammary glands. These are the 4 types of control in the endocrine system. Exocrine, yeah, exocrine's all about that epithelial surface, whether it's on the intestines or the skin, both epithelial there. Classifications of disorders. So these are like hormone disorders just in general. This is going to be testing. Oh, is this not on? Hello? Oh, there we go. Testing. All right, we're good. Classification of disorders, primary, it's kind of the opposite, right? Start far away, issue with the target organ. Yes. This is big. So ACTH, there's this precursor called pro-opiomelanocortin, which breaks down into ACTH itself, but then also melanocyte stimulating hormone from that intermediate pituitary. That's important. That is going to be a test question. Paracrine neighboring cells. There's 2 options here. Somatostatin is one. I don't know. Histamine. Sure. Yeah, that's like a local reaction. Melanocyte intermediate. We already said that. This is simply flute theater act. This is ACTH, adrenocorticotropic hormone. So this is one of the non-traditional hormone secreting organs, leptin, adiponectin. Is that what we just learned about in diagnostics? That's going to be adipose tissue. Adrenal glands, cortisol production stimulate what production? Androgen. Yeah, that's big. That's actually where testosterone is produced, and then I think it moves down to the testes and the ovaries. Cool. We'll take that. This is going to be, so it's endocrine, upper right, I don't remember. Bottom left is going to be exocrine. Okay, autocrine. Corticotroph cells, opiomelanocortin. Okay, opio means something. Melanocortin, the 2 names are in there. Cortex, so this is medulla on the right. ADH, blank and blank for maintenance of water. Eh? Oh, kidneys and arterioles. These are the targets. Negative, all about balance here and homeostasis. Yeah, it's like temperature setting. Hypovolemia, nausea will upregulate ADH. Sure. Blank tissues for growth hormone. All body tissues, general, yeah. It's worth noting that the hypothalamus also produces these 2 direct hormones. That's going to be oxytocin and vasopressin. And then they travel to the posterior pituitary. Feedback, like blank. The example here is T3 and TSH. Or hypothyroidism. When we have hypothyroidism, we're going to increase TSH to then push out more T3, right? Prolactin. The master gland sits 5 to 10 below the optic chiasm, rests in the cell tertiary. This is the pituitary, so it's HOP, right? It's hypothalamus, optic chiasm, pituitary. So pituitary is definitely the master gland. Melanocytes peak in pregnancy. Pineal gland, part of the epithalamus. Pituitary rests in the cell tertiary, testes for production of testosterone. Anterior pituitary, what type of cells here? I don't know. Lactotroph, sure. ADH, upper right. Oh, triiodothyronine. We'll take that. What is the master gland? Pituitary. Pituitary, general body tissues for muscle tissue growth, protein synthesis, lipid metabolism. Anti-insulin. Okay, yeah, that's important there for sure. That's why it goes up during sleep and stress and exercise. Anything where we need sugar, we're going to shut off insulin. That makes sense. Regulated by thyroid releasing hormone, thyrotropin, whatever. T4's name is Thyroxine? Yeah. Just for blank for inhibin B. What? Anterior pituitary. Oh, yeah. We'll see that when we go back to the pituitaries. Which two pituitary hormones receive stimulation from the hypothalamus without an off inhibitor? Very important here. Fluid theater. So thyroid stimulating hormone and then adrenocorticotropic hormone. Yes. So they have these on things and then but they don't have an off. The off inhibition is controlled by like other things. Feedback, another example, blood clotting of positive. This is going to be kidneys, gonads secrete progesterone inhibin. What is missing? Estrogen? Let's go. All right. What upregulates luteinizing hormone? Oh, why would you do this? Elevated testosterone, elevated estrogens. Low testosterone and estrogens? Puberty. Okay. And pulsatile release. Puberty, I think, is a big one there. Adrenal glands, cortisol, androgens. What's missing? Oh, come on. I don't know. Aldosterone. Oh, that's pretty important. Pituitary, oxytocin. What slows down oxytocin? Oh, progesterone. Let's go. All right, this is your classic endocrine function. Yeah, just the word endocrine. Gonads, estrogen, progesterone. What's missing? Inhibin B. Yeah, so if we look at FSH here, we see one of the inhibitors of FSH is inhibin from Sertoli cells. I think that's important. Thyroid stimulating hormone comes from what cells? Thyrotropin? That's exactly right. All right, cortex on the left for adrenal glands. Target of testes, what kind of cells? Leydig? Let's go. ACTH, what upregulates it? Stress and glucagon? Oh, circadian rhythm. Sure. Heart, maybe that has something to do with melanocyte, the melanocyte part of that. That makes sense. Heart is just going to be your natriuretic peptides like BNP. Cortex, aldosterone, androgens. What's missing? You were just looking at it. Doesn't it start with a C? Cortisol. Regulated by gonadotropin releasing. Yes. This is just melanocyte stimulating hormone. This also starts with an A. Cortisol, aldosterone, and androgens in the cortex. What upregulates follicle stimulating hormone? Puberty and pulsatile release. Adipose tissue. Ooh. Adiponectin and lepto something? Just leptin. We'll take that. Upper left is FSH. Bottom right, peak in pregnancy. Yeah, cholasma, which is something with your face. I think it's just yeah, just brown patches on the face. Something like that. Okay. We'll take that. Sleep, stress, trauma, growth hormone. It's an important one. What is it? I don't know. Exercise. All about like augmentation, exaggeration. What Linnea nigra, good. Secondary issue with the blank making the stimulating hormone. Yeah, so we work back. So primary is an issue with the target organ. Secondary is an issue with like the gland making the hormone. Perfect. And then tertiary would be the hypothalamus itself, right? What's causing the stimulus for all of this. Paracrine neighboring cells, we have histamine and somatostatin. Growth hormone, this is going to be, I don't know, somatotroph cells. Okay, it's kind of a weird word. Autocrine acts on itself. Whereas vasopressin produced hypothalamus? Yep. Ovaries for menstrual cycles and blank production. Estrogen. This is going to be the intestines with cytokines, secretins, and ghrelin. Tertiary, an issue with the hypothalamus. What is the main regulator? So hypothalamus, which connects the blank to the endocrine system, the central nervous system. Yeah, and there's our HOP, hypothalamus, optic chiasm, pituitary gland. Classification of disorders. This is just, oh yeah, primary, secondary, tertiary. Pineal gland secretes what? Melatonin. What is the main regulator? It's the hypothalamus. Bottom right is going to be paracrine. This is going to be negative feedback loop. This is going to be the heart. Kidneys and arterioles for maintenance of water, glucose, salt levels in plasma. Vasoconstriction. Let's go. No blank regulator for prolactin, hypothalamic. The anterior pituitary lacks a major direct blood supply. That's really important for things. Prolactin, nipple stimulation. Growth hormone. What's going to pause growth hormone? Insulin, somatostatin. Okay. Exocrine, like, yeah, this is actually epithelial cells. This is going to be like amylase and lipase, like from the pancreas right into the duodenum, right? Axon itself, autocrine. Bottom left is oxytocin. Progesterone inhibits oxytocin. Let's go. Located at the base of the brain, just blank. To the optic chiasm, hypothalamus just above it. In order superior to inferior, hypothalamus, optic chiasm, pituitary. Blank from Sertoli cells. What inhibits follicle stimulating hormone? Inhibin. Fasting, growth hormone. Oh, what is this? Ghrelin. Why does ghrelin? Yeah, we're hungry. This is this all makes sense. We're asleep, technically fasting, and then ghrelin, it's hunger. It's going to increase that growth hormone. Hypovolemia, nausea, and another one. Really help to have context here, mannitol. Blank and blank for maintenance of water. So what's the targets of vasopressin? Kidneys and blood vessels? We'll take that, arterioles. Hypovolemia, blank, mannitol, nausea. The way I think of this is like nausea, the body's almost like we're probably about to lose some fluid via vomiting, so we should probably hold on to some water. That's probably why that works. Paracrine, neighboring cells, somatostatin. This is just another example of paracrine. Oh, histamines. General lipid metabolism. I don't know. Anti-insulin, yeah, again, really important there. Blank for inhibin, that's going to go to the anterior pituitary. Prolactin is going to be lactotroph cells. Cortisol, so this is CAA for the cortex. This is going to be not androgens, but aldosterone for the adrenal glands. My mnemonic here is texting all dose ladies. So all dose as aldosterone, texting for cortex. What's going to stimulate adrenocorticotropic hormones? Stress and, I don't know, circadian rhythm. Yeah, remember that melanocyte connection. That's going to help you there. What upregulates luteinizing hormone? Puberty and pulsatile release. Anterior pituitary comes from somatotroph cells, which kind of connects to the inhibitor of somatostatin, if that's sure. Somatostatin. Sleep, stress, trauma. You said this was important, right? What would make us fasting, sleep? It's not exercise, is it? Oh, let's go. Blank gland, part of epithalamus, secretes melatonin, pineal gland. The pituitary, breast tissue, prolactin specifically. The last one here, sleep, stress, trauma, exercise, fasting, ghrelin. Hormones are usually bound to plasma proteins. Birth, emotion, orgasm. This upregulates oxytocin. Anterior pituitary. Corticotroph cells. Gonadotroph cells. Good. All right, good. We've seen every card, so now we just got to hit them and send them to tomorrow. Oxytocin produced in hypothalamus. General body tissues for muscle tissue growth, lipid metabolism. Oh, what is this? Oh, it's anti-insulin. Growth hormone is anti-insulin. Gonadotroph cells. Stress. What's going to upregulate adrenocorticotropic hormone? Why do we need cortisol? Why do we need stress? Why do we need this? Oh, circadian rhythm. The ones without hypothalamic regulators, ACTH, TSH, upper right corner, and then left middle. Hypovolemia, nausea, mannitol for vasopressin. And was that a stimulator or an inhibitor? I don't remember, but it was bottom left corner of that box, so I know it's a stimulator of vasopressin. Intestine, CIG, cytokines. Incretin, not inhibin, incretin lives here. Inhibin is in the ovaries. G here is going to be ghrelin. Very good. So luteinizing hormone is upper middle. This is growth hormone. Testes for spermatogenesis lives with FSH. That's important. Upregulate is low T3. What causes it is high T3. Estrogen, inhibin, what's missing? Progesterone, which prepares the uterus for pregnancy and mammary glands for lactation, and it inhibits oxytocin. Growth hormone. Fasting is already there. Stress and trauma are there. Exercise. Sleep. Let's go. Targets, blank for uterine contraction and milk letdown. The uterus and the mammary glands. Parathyroid regulates calcium and phosphorus. How does the pituitary get all of its hormones all over the body? Venous drainage to the sinuses and jugular vein, cavernous sinuses. We'll take it. Regulated by gonadotroph, releasing hormones, gonadotroph and whatever. Primary issue with the gland itself, target organ. That's kind of what I meant, but we got to redo that. Melanocyte stimulating hormone is in the intermediate pituitary. Medulla secretes. It's men, so it's epinephrine and norepinephrine of the adrenal glands. This is simply fluid theater act, so adrenocorticotropic hormone. Kidney is EPO and renin. This is positive feedback. All that bounce in homeostasis for negative. Fluid theater, so TSH, ACTH, and melanocyte stimulating hormone. Let's go. Pineal gland, part of epithalamus, master gland, pituitary, medulla, peak in pregnancy, primary issue with the target organ. Opiomelanocorticoin, opiomelanocortin, sure. Vasopressin, adipose tissue, release a substance out through duct onto an epithelial surface. Stimulate androgen production. That's a good one. I'm going to mark that as hard so we see that more. Triiodothyronine. We'll take that. Secrete. What's missing? Progesterone, inhibin, estrogen. Controls ovulation, secondary sex traits. Prolactin. Blood clotting. All body tissues. Thyroid releasing hormone, thyrotropin, whatever. Endocrine, autocrine, bottom left is just exocrine. That's exocrine is going to be epithelial. It's worth noting a hypothalamus also produces these two direct hormones, ADH and oxytocin. Gonads target Leydig cells. Testes for production of testosterone. What inhibits oxytocin? Progesterone. Pituitary rests in the cella turcica, like hypothyroidism and TSH, high TSH are going to be negative feedback. What is a master gland? Pituitary. Adrenal glands. What is not the medulla? The cortex. Which two pituitary hormones receive without an offender? TSH and ACTH. Yes, this is just giving me the releasing hormones. Types of control, what's the first one? And the word endocrine. EPO and renin is kidneys. Peak in pregnancy, cholasma, which we see in the face. And linea nigra, which we see in the abdomen. CAA, cortisol, aldosterone, and androgens. T3 and T4, which is thyroxine. FSH, leptin and adiponectin. Let's go. Secondary issue with so it's not the hypothalamus, it's not the target organ, this is the gland. Melanocyte stimulating hormone, straight up an issue with the hypothalamus, that's tertiary, that's important. All right, we're 43 away here. What is the main regulator? It's the hypothalamus. Estrogen, progesterone, what's missing? Inhibin, which goes to the anterior pituitary, which inhibits FSH. Ovaries, menstrual cycles, and what production? Estrogen. No hypothalamic regulator for prolactin. Cortex, CAA, cortisol. Kidneys and arterioles for maintenance of water, glucose, salt levels, and plasma. Vasoconstriction. Anterior pituitary, thyroid comes from thyrotrophin cells, sure. Negative feedback loop. Regulated by gonadotropin, releasing hormones. What from Sertoli cells would inhibit FSH? I don't know. Inhibin. Oh, we knew that. Heart, natriuretic peptides. Inhibin. Yeah, we'll see that one again. Pineal gland secretes. Think about it. Melatonin. Good. Located in the base of the brain, just above the optic chiasm. Types of control, bottom right is paracrine. That's our neighborhood, all about positive augmentation, exaggeration. Autocrine acts on itself. What is the main regulator which connects the CNS? Nipple stimulation. What is going to upregulate FSH? Puberty and pulsatile release. Neighboring cells. What also from somatostatin? Oh, histamines. Somatostatin. Heart. What goes up? What do we need for inhibin? Oh, it goes to the anterior pituitary to stop FSH. Intestines. Primary, secondary, tertiary. Oxytocin. Aldosterone. Hypothalamus. Itself. Pulsatile release puberty. Oxytocin. Oh, what is this? Exercise. Anterior pituitary lacks a major direct blood supply. Arterial supply. Targets for ADH. Arterioles and kidney. Amylase lipase. Hypothalamus, optic chiasm, pituitary. Hypovolemia, nausea. Mannitol will upregulate vasopressin. Nausea will do it too. Lactotroph cells. Somatotroph cells. Let's go. Somatotropin. Somatostatin. Whatever. Sleep, stress, trauma, exercise, fasting. Oh, what's the last one? Think about this. What's going to upregulate growth hormone? Where sleep, we need sugar. Fasting. It has something to do with like hypoglycemia. Oh, it's gonna kill me. Sleep. Hey, we need sugar. We're fasting. Stress and trauma as well. Exercise, fasting. What would we need to grow for? Oh, this is gonna kill me. Growth hormone. We're asleep. Upregulate some stuff. We're stressed or traumatized. Upregulate some stuff. We're exercising. We need more things. Fasting. We need more things. What is this? Oh, freaking ghrelin. God dang it. General body tissues for muscle tissue growth, protein synthesis, lipid metabolism. Growth hormone is anti-insulin. Ghrelin. All right. We only have 5 cards left, so it's going to keep showing me that. Man. ACTH, stress, and what else? Circadian rhythm. Ghrelin. Adrenal glands, cortisol production stimulates what production? Androgens. Ghrelin. What from Sertoli cells? Inhibit. Primary is an issue with the target organ. That's it. That's it. One entire PowerPoint down. 203 cards in diabetes. This is the worst. Okay. Medication-induced diabetes. Steroids, something, and niacin. Oral contraceptives. Let's go. We see glucosuria when serum glucose is greater than 180. Genetic features of both, LADA's genetic features of both DM1 and DM2. There are no blank involved in monogenic diabetes. Antibodies. The 4Gs, glycogenesis, gluconeogenesis, and glycogenolysis. Insulin deficiencies, mild and marked. What comes out of epsilon cells? Ghrelin again, right? Freaking ghrelin. We can lose 70% of these bad boys until any dysfunction occurs. The islets of Langerhans, islets, islets, whatever. The big four. Oh, don't do this to me. A1C. Oh, man. What inhibits glycogenolysis? Glucose? Or the insulin? Hey, we have enough sugar. Stop. That makes sense. DM1, look for family history of other autoimmune conditions besides diabetes, like Sjogren's, rheumatoid arthritis, lupus. Oh, come on. Vitiligo. A lot of patients will have LADA-GADA, right? So anti-GAD antibodies? Yes. 4Gs, glucagon. All right. What stimulates gluconeogenesis? Glucagon, fasting, acidosis. Bottom right, LADA. Other stuff that causes diabetes, Cushing's. Because there's a cortisol overload, cortisol is also anti-insulin. That wasn't on the other. We didn't have that on the other one, but that's important. DM2 is an insulin resistance. What is our fourth thing? This is a random fasting glucose over 200 and symptoms. Beta cells, what percent? Is this like 60? Yeah, just know that they're the majority. Fatty acid production and what storage? Is there targets of insulin? Triglyceride. Hypoglycemia, glucagon kicks on, triggers hepatic glucose and ketone output. Protein meals, what stimulates glucagon? Protein meals, blank, ketones, cortisol. Catecholamines, yes. You want to think glucagon, sympathetic, insulin, parasympathetic, for sure. Let's talk about fasting. The problem, however, is we only have about blank hours of stead stores of glycogen, 24. Interference of insulin release. Thiazides, phenytoin, cyclosporin. It's an anti-rejection med. Look for that in a kidney transplant vignette or something like that. What inhibits insulin? Somatostatin slows it down. What's going to say we need sugar? Glucagon, catecholamines. Okay. This is a great measurement since it measures the average blood glucose over 120 days. A1C. Oh my God, there's 178 cards I have to get through. Glycogenolysis, upper right is going to be glycogenesis. Glucagon, catabolic, insulin anabolic. PP cells, pancreatic polypeptide of the pancreas of the islets of Langerhans, which drain to the hepatic portal vein. All individuals with at least blank confirmed diabetes-related autoantibodies require metabolic monitoring. 2, beta cells, insulin. So pro-insulin gets cut into insulin, and C, protein, peptide. Oh, that is a amateur mistake. Screening for gestational diabetes to test, do a oral glucose tolerance test. First step in gluconeogenesis, pyruvate. Okay, hypoglycemia triggers muscle protein breakdown and adipose tissue breakdown, yes? Yeah, catabolism. All right, polyuria. Why in diabetes mellitus do we get polyuria? What a loaded question. One is we just have too much sugar. So it's going through our glomerulus. It's in our urine. It increases tonicity. Tonicity is going to pull in water. Yes? That's exactly right. Upon an initial diagnosis, a lot of patients don't need blank, but they will after months to years. Insulin. Gestational diabetes, we'll see increased progesterone, blank, and prolactin. Estrogen, cortisol. Okay. All right. Oral glucose tolerance test, OGTT. What confirms diabetes? I think it's just simply over 200. Yep. Gestational diabetes over blank is positive here. For that second part, oral glucose, isn't it 200? Yeah, sweet. To help reduce risk of diabetes, exercise 150 minutes a week. Stimulated by, all right, so gluconeogenesis is stimulated by something, fasting, and acidosis. It's got to be glucagon. Yeah. All right. Mild insulin deficiency and marked insulin deficiency, we're failing our OGTT. Pancreas. Delta cells, somatostatin. Presence and titers of anti-blank, anti-GAD antibodies for LATA. Good. Just the word glucagon. Oh, counter-regulatory hormones to insulin. Let's see if we can name them. It's good. Spells goodnight egg. Growth hormone, norepinephrine, epinephrine. Right? Goodnight egg? Yes. I think. Maybe it's glycogen, norepinephrine, epinephrine, growth hormone, and something else. Glucagon. I may have said glycogen. Glucagon, norepi. Oh, glucocorticoids like cortisol. Okay. So this and this. Okay. We'll hit that again. Diazide cyclosporin. What's missing here for insulin release? I don't. Oh, no. I don't know. Phenytoin. Other causes: congenital rubella, fasting. At about blank hours, blank kicks in because our body's getting worried. 12 hours, gluconeogenesis kicks in. To calculate, just take an A1C and multiply by, isn't it 20? Yeah, that's crazy. I didn't know that. To figure out like what their glucose is. DM1, why do we get weight loss? So we're peeing out sugar. Yeah, we have this insulin deficiency, so we can't use the carbs we're eating. So we're just peeing out our food. It's crazy. Yeah, that's exactly right. All right. Associated conditions of metabolic syndrome. PCOS, I think, was one that stood out to me. Blank antibodies most common with DM type 1. Oh, this is like a weird name. Just islet cells? Yeah. I think blank are important because they can be used for 90% of energy needed for the brain to keep functioning. Ketones, ketone bodies. Central obesity measured by waist circumference. Is it 40 in men, 30 in women? 35 in women. Give me a break. The big four. If your level is blank for an OGTT, then we have to do a 3-hour test. Over 100? 140. Risk factors for DM2. I'm actually going to bury this card because I have something else for this. I don't know if I made a card, but we'll see if we can remember. Okay. Associated conditions of metabolic syndrome. So we already mentioned PCOS. Another one here is going to be like hyperuricemia or gout. Metabolic syndrome. Oh, this is just testing the numbers. All right, hyperglycemia, fasting glucose between, I don't know, 125 to 150, 100 to 125. Adipose tissue, this is targets of insulin. This is going to be just lipid production, or is it fatty acid production? Fatty acid production. All right, presentation of DM type 1, polyuria, polydipsia, probably weight loss is on there. Yep, that's a big one. We'll see increased progesterone, cortisol, prolactin for gestational diabetes. Insulin, what's the third target? It spells LAM, so it's muscle. A question as old as time itself, why does your blood sugar not drop overnight? Many reasons, right? I think glycogenolysis kicks in. Growth hormone is going to kick in as well. That's exactly right. Yeah, glycogenolysis. What is the A of the targets of insulin? Adipose tissue. If you see acanthosis nigricans, these are signs of DM2. We also saw something similar, but with melanocyte stimulating hormone. Insulin, if blank is not sufficient for gestational diabetes. Lifestyle. Key takeaway here is that blood from the islets drain directly into the hepatic portal vein. That's why the liver is the main site of insulin and glucagon action. That makes sense, right? That's where a lot of glycogen stores are. It's liver and muscle. That makes so much sense. Slowest source of energy, fats. Which is actually like technically a good thing because it can last longer, right? Induction of insulin resistance, just a random med, antipsychotics. Progesterone, cortisol, prolactin, and gestational diabetes. Occurrence of non-insulin dependent DM in late childhood, but younger than 25. That's the big thing for monogenic is that number 25. Glycogenesis inhibited by glucagon and just glucose, epinephrine. Can cause, LATA can cause what? Oh, like DKA and HHS. Yeah, that's big. Screening for type 1 DM, first and second degree relatives with individuals with type 1, you want to do antibody testing, autoantibody testing. If you see blank acanthosis, destruction of beta cells, IV. Oh, what is this? It's not protamine. I think it has a P in it. Pentamidine. Okay. Treatment for DM type 1. Yeah, insulin's your only option there. Induction of insulin resistance, steroids, OCP. Does niacin live here? Yes, it does. Because of the incretin effect, blank produces greater insulin response in IV oral glucose. This is in the GLP bucket. Alpha, beta, what secretes somatostatin? Delta. This tapers off after 48. Yeah. Gluconeogenesis tapers off after 48. Starts at 12, peaks at 24, tapers at 48. All right, we're down below 125. Let's celebrate every 25 we hit. Pancreas, the exocrine functions come from what cells? Oh, Acini cells. I don't know that we need to know that, but it's good to know. Where do glycogenolysis and glycogenesis happen? Muscle and liver. Geez. Believe it or not, blank can resolve type 2 DM. Weight loss. It's estimated that 1 in blank children born after, 3. That's crazy. Look for family history of other immune conditions besides diabetes like vitiligo. So that's for DM1 and bottom right, which is going to be LATA. The ADA says to screen all individuals over what age every 3 years? 45. Muscle, glycogenesis, and what synthesis? Protein for insulin. Yeah. Mild insulin deficiency. And Mark, what's the difference? So mild insulin deficiency, our basal rate is fine, but we can't handle this postprandial load. Marked insulin deficiency, our basal rate is not fine. We're just baseline hyperglycemic. I guess we're not quite hyperglycemic to be diabetic, but we're insulin deficient. So we're moving towards that DM type 2, right? And OGTTs failed in both. Which wouldn't mean you just have diabetes. I don't know. So remember that blank inhibits both insulin and glucose, somatostatin. Chronic alcoholic pancreatitis can cause, ooh, that's broad, diabetes. Inhibition of insulin release or interference, whatever. So that's going to be our far left. Can you name any that were there? Phenytoin lives over there. A stronger blank predisposition. Yeah, stronger genetic with DM type 2. That's really big. Treatment for metabolic syndrome. I don't know that I know this. Aren't like ACEs and ARBs down here? They are. Okay, so metformin, statins, and ACEs and ARBs. All right. Metabolic syndrome, we're looking for numbers here. What arbitrary hypertension number are we worried about? At what point? Always 130 over 85. Yes, let's go. That's crazy. This is why the blank is the main site of insulin liver. All right, let's pick up the pace. All individuals with at least blank confirmed diabetes 2. 45 every 3 years. Human something lactogen. Placenta? Placental, we'll take that. We get blurred vision with DM type 2. Yeah, we sure do. Look for a history of other autoimmune conditions with DM1. All individuals at least require metabolic monitoring. History of gestational diabetes sets you up for DM type 2. Yep, sure does. Fasting blood sugar. So what is our pre-diabetic level for fasting? Got to be 100 to 125. What type of inhibitor induction? This is protease? Yeah, protease. Okay. So middle column, induction of so these are insulin resistance, not release. That's important. So it spells SOAP, S-O-A-P, N SOAP. I don't know. I have to do an SOAP note. The endocrine cells are, is it line your hands? Oh, we're down below 100. Glucagon, inhibited by what? What would inhibit glucagon? Insulin? Anything parasympathetic, right? Insulin's got to be on there. What would say we don't need sugar? Like hyperglycemia? Okay, we'll take that. Glucose, we said insulin, and somatostatin. All right, I'm going to give that. All right, what confirms diabetes and fasting blood sugar? If 100 to 120, it's over 126. That's big. Diabetes mellitus, occurrence of non-insulin dependent DM in late childhood? Yeah. So that is what bucket is that even in? That's MODA, whatever that's called. Inhibited by blank glycogenolysis. Insulin. Targets of insulin. LAM, what is the first one? The liver, right? Insulin is going to, you can't just look, increase glycogenesis. That makes sense. It's parasympathetic. It's anabolic. It wants us to turn usable glucose into non-usable stored glycogen. That tracks. DM type 1 is insulin deficiency. DM type 2 is like, yeah, 90 to 95%. So much more common. Glycogenesis is stimulated by insulin and elevated what? What would stimulate the need for storage of sugar? It's got to be elevated glucose. It's got to be elevated glucose. Nice. Gestational diabetes. The big four. What is this one? So what's missing? Oh, OGTT. GLP is a type of incretin which are insulin augmenters secreted by blank in the small intestine. L cells. All right, what's a positive A1C for prediabetes? That's a great question. Isn't it 5.7 to 6.4? Let's go, baby. All right, destruction of beta cells. This is going to be our most severe medication-induced diabetes. Yeah, that's nuts. IV pentamidine. It's an anti-infective. I don't know exactly what it's for. All right, what's pre-diabetic for OGTT? 140 to 199? Yeah, exactly. Well, 140 to 200. We have to be greater than 200. We'll take that. Glucagon, insulin. Occurs in liver and not muscle, kidney. That's important. Gluconeogenesis. My hypothesis there is when we're creating glucose from non-glucose precursors, the kidney's like, well, what do you need? You need some more like protein, you need some more lipids. I'll hold on to some of that. I don't know if that's true, but that's going to help me remember that. Look for vitiligo. Inhibited by. So insulin's inhibited by somatostatin and what else? Epinephrine. Yeah, catecholamines. We'll take that. A monogenic diabetes. MODI was the other name. A blank defect in glucose. Partial. Beta cells. C. Peptide and proinsulin. Yes, okay. We'll mark that as hard. Autosomal dominant. When do we test? Second half of gestation. So gestation is like every 12 weeks. But that's a trimester. So what's the second half of 40? Okay, after 20. I think we tested 24 weeks. Yes. So the beginning of the second trimester. Right? Sure. Triggers hepatic glucose and what output? Hypoglycemia, just glucose? Ketone. Oh, that's important. All right. What stimulates glucagon? Protein meals, something, ketones, and cortisol. Speaking of hunger, I don't know. Catecholamines. All right. Think about it. Glycosuria begins when serum glucose is over 180. Autoantibodies, polyuria. Gluconeogenesis begins at 12. Lactogen. LATA is insulin, but not at first. No, that's a dumb card. Hypertriglyceridemia. What puts you in metabolic syndrome? Greater than 145. Oh, come on, 150. Interference of insulin release. Thiazide cyclosporin, what's missing? I don't remember. Phenytoin. TPC. PTC. PCT. Patient Care Tech. Okay. Screening for type 1 DM. All right, we're below 75. All right, so for screening all individuals with at least 2 confirmed autoantibodies, yes, so the big threshold here is less than 5, greater than 5. Less than 5, monitor every 3 to 6. Greater than 5, every 6 to 12. That's exactly right. Gestational diabetes will see increased progesterone, something, and prolactin. Inhibin, cortisol. The ADA says to screen all individuals over 45 every 3 years. Eilers Langerhans only 1 to 1.5 of total pancreatic volume. Isn't that crazy? And we can lose up to 60, 70% before we see anything. Induction of insulin, that's release. So this should be resistance. Second half. Sorry if this is rude. Augmenters. What stimulates? It's got to be insulin. What is just the name of this? Gluconeogenesis. To diagnose DM1, we order pancreatic antibodies. Oh, AII? I don't know that I want to know this IA2ZNT8 thing. They're just random letters. All right, at the liver, glycogenesis, store this sugar, and what synthesis while we're there? Let's make some lipids while we're there, right? Forty 35. DM2. Last longer. All right, let me finish this bite. This is gross. Okay, why is a high protein diet good for weight loss? Yeah, it lasts longer. So we don't have to eat as soon after. The big four, if your level is what, we move on to the 3-hour test. Isn't it over 100? I think it's 140. Yes, I think 100 is for the gestational one. All right, after this, we're going to take a lunch break. That's my inspiration here. All right, metabolic syndrome. Fasting glucose between blank for hyperglycemia. 100 or 125. All right, what is going to inhibit glycogenesis? Glucagon and so what's going to inhibit storage? Catecholamines, epinephrine. Good job. We are recording. You can hear me. Okay. IV. What's this anti-effect? It starts with a P. Pentamidine. Oh, what did this? Soap. It spells. I have to do an soap. Antipsychotics. We see glucoserum when serum glucose is greater than 180. Oh, okay. So here is my mnemonic for the risk factors for DM2. I have connected one to the months of the year. So June, we actually came up with junky veins. Janky veins or vasculature. So January is ethnicity because we say Happy New Year from all around the world. This is basically everything but Caucasian, like Hispanic, African American, Pacific Islander, Asian. February is, oh, what was it for February? Did it just start with an F? I think it's, is it family history? March is going to be gestational diabetes. Oh, it's first degree relative. No, that's pretty much the same thing. We'll take that. We can lose 70% of, as the Langerhans. Yeah, the lens of the eye gets messed up in DM2, so we get blurred vision. That's pretty crazy. Hemoglobin A1C, what is diabetic? 6 greater than 6.5. Or technically 6.5 and higher, yes. DM1 can present as DKA. Yes, it's more commonly presented as DKA. I think DM2 is more HHS. Mild and marked. Insulin resistance. Something else. Is it like a fungal thing? Yeah, candidiasis. A1C. Triglyceride. What stimulates glycogenolysis? What stimulates the breakdown of glycogen to glucose? Starving, fasting, hunger, hypoglycemia, epinephrine, catecholamines. Okay, and glucagon itself. Sure. Treatment of metabolic syndrome. Metformin, ACEs and ARBs, and statins. Beta cells, 60%. Monogenic diabetes. We have an insulin resistance effect. Yeah, definitely cortisol there as well for gestational diabetes. Ghrelin stimulates blank hormone, induces gastric damping. Oh, growth hormone. Let's go. See, good connection. That's going to help me remember that other one. Speaking of, if I go back here, that should be waiting for me. Yep. So growth hormone. Oh, yes. Upregulates because we're hungry. I think I knew that. What are we up to? We're already up to 426 cards in an hour. That is pretty good. This is spring semester is another beast. Glycogenesis. This is going to be glycogenolysis. Genetic features of both DM1 and DM2. A lot of patients will have anti-GAD. All right. More arbitrary numbers. Metabolic syndrome, low HDL. I don't know. And that's the other thing. It's like diagnostics is tomorrow. This is the worst. Okay, 40 and 50. All right. Oh, no, we don't get credit for that. All right, so this is our N soap. So what is missing here? O, oral contraceptives. And that is for insulin resistance, stimulants of insulin resistance, releases to the left. This is glycogenesis. The name of this is latent autoimmune diabetic, something with an A, in adults. All individuals with at least 2 confirmed diabetes related on it. Autoantibodies need that metabolic monitoring. Ghrelin lives there. Yes, which stimulates growth hormone. There are no blank involved in monogenic diabetes antibodies. 24 hours of glycogen. Greater than 200 random glucose and end symptoms. Cushing's. Screen earlier if BMI and one of these. 25? DM1, polyuria, we already kind of talked about that. Over what is positive for a GDT? This is for the gestational diabetes one. Is it not 140? I think it's 100, 200. To diagnose DM1, we order pancreatic antibodies. What's the 65 one? I don't remember that. GAD 65. Okay. Stimulated, gluconeogenesis, glucose fasting, acidosis. That's a big one. Let's hard that one. Triggers hepatic glucose and cortisol. Oh, ketone. All right, April sounds like a beta blocker. Hypertension. May, metabolic syndrome. And June is your junkie vein, so history of vascular disease. Most commonly presents in childhood, but quarter can present in adulthood, usually not. Obese in DM1, yeah. Hepatic portal. Type 2 DM because it's thought that blank is the main source of resistance. Adipose tissue, that's big. Alpha, beta, delta. Epsilon. Insulin is stimulated by glucose and what else? What would say we need to store more? Like hyperglycemia, I feel like that's not it though. It's not a catecholamine. Oh, vagal stimulation. That's actually really important because it's a parasympathetic response, which is anabolic. This is just pancreatic polyp PP cells. All right, patient care tech. So this is a C, this is cyclosporin. Catabolic, anabolic. What is diabetic for OGTT? Don't look at the pre-diabetic one. Is it greater than 200? Yeah. Occurs in liver and kidney for gluconeogenesis. 120. Protein meals, something, ketones, and cortisol. What's going to stimulate glucagon? What we need sugar. Like exercise, activity, catecholamines. Glycosuria, muscle protein, breakdown, adipose tissue, catabolism. GLP, just GLP-1? Yeah, just GLP, glucagon-like peptide. These are those incretin insulin augmenters. At about 12 hours gluconeogenesis kicks in. Hypertriglyceridemia. What is is this 145? 150, come on. 150, 150, 150. Why do we get weight loss? We already talked about that. This is like more, this is DM1. We're peeing out the sugar because we have insulin deficiency. OGTT, rubella, pyruvate. 3 to 8% pregnant, but incidence doubles in, is this Native American? Yep. 150. T cell mediated. PCT, thiazides, proglucagon. Come on, let's pick up the pace. Can sustain us for a 24-hour fast. Not hypercoagulable, hypertonic, hyperosmolar. The steps of starving blank for 24 hours until no more glycogen. Glycogenolysis. Insulin. Ketones. PCOS. By the way, for metabolic syndrome, my mnemonic for remembering the 5 associated conditions, fat thumbs. So it's central obesity. No offense to anybody. It's just how I remember it. I have fat thumbs. When you try something with sugar on it, you put out your fingertip. That's hyperglycemia. When you flip somebody off, it's very tense, hypertension. When you hold up your ring finger for the number 3, triglyceridemia. And then when you can use your entire hand, it's low HDL. OGTT. Presence and titers of GAD lives down there for LATA. We'll see increased progesterone, prolactin, and cortisol. I'm going to mark that hard, which is this one. Progesterone, glucagon. Stimulated by something, fasting, and acidosis, gluconeogenesis. Like exercise, activity, glucagon. Okay. Presentation, polyuria, polydipsia, and weight loss. That is the big one for DM1. Somatostatin. See, acanthosis nigricans. You might have diabetes, so get your A1C checked. Growth hormone induces what? What does growth hormone induce? Oh, gastric emptying. The slowest source of energy are fats. Islet antibodies. Thiazide, cyclosporin. There's a P here. Oh. Medicine that starts with a P. Isn't it Dilantin? Phenytoin can cause DK, HHS, beta cells, insulin. What are you asking me here? Oh, the other thing, GABA, yeah. Oh, when I did this, this is the most fun part. So you need at least 3 of these. So basically you need the majority of these. So it would be 2.5 to 3. To calculate, just take the A1C multiply by 20. All right, we're below 25 and we got 125 reviews. We're getting there. Induction of insulin resistance. This is an soap, so we're missing our S. Is it statins? Steroids. No, statins wouldn't make sense. Those are good. Hepatic, pancreas, hepatic portal vein. Hyperuricemia, gout. Fatty acid, proinsulin, and C peptide. Pancreatic polypeptide. Lifestyle. Autoantibodies. Tinea pedis. Isn't it just like athlete's foot, like foot fungus? Management of diabetes. There are some measurable goals we should remember. A1C less than 6.5. I feel like it's higher. I feel like it's like 7. 6.5 is okay. We'll take that. All right. So, and soap. So we're missing the N. This is niacin. Glucagon kicks in. Glycogenolysis. 48. Acanthosis. Adipose tissue. Muscle. Target of glucagon. Liver and probably muscles. 45. Scandinavian. Weight loss. Insulin. Vitiligo. So vitiligo lives in these corners. Born with this. Screening for diabetes. Oh, these are reasons to screen earlier than 45 if your BMI is greater than 25. Ethnicity is one of them. Okay, moving on to the second half of the year. July is BMI because we kind of pig out during 4th of July. It's greater than 25. August is age greater than 45. That's when we start screening. September is I don't remember September. Think about this. Does it start with an I think it's does it start with an SE? I don't know. Sedentary. Mild insulin deficiency. We already kind of talked about this. Basal's fine. Marked insulin, your baseline hyperglycemic. Progesterone, cortisol, and prolactin. This is delta cells. Steps of starving. 24 hours of what are you saying here? Gluconeogenesis, this stands for 40. Okay, it's not a great card. Metabolic syndrome. Yeah, we already said these 5. 25. Somatostatin. 13 more new ones. We're almost down to 100 reviews. Oral glucose. What oral glucose what? Just a better response? Yeah, greater insulin response. Occurs in liver and muscle. Genetic. The exocrine functions come from what cells? Oh, acini. Yeah, it's not a 3. Gestational would be another reason to screen somebody less than 45. Actually, if you have that, you get screened for life every 3 years. Monitoring. Placental. To I'm running out of gas over here. Fasting blood sugar. What's positive for diabetes? 126 and up. That's like really important. Langerhans. Insulin. Induction. Interference. Liver. Blurred. By the way, like, I just need to know blurred lives in the upper right corner. So if a patient comes with blurred vision or says, what type of diabetes presents with blurred vision? I know it's diabetes too. I remember every single box that these are in because you can just feel the direction it's in. This is crazy powerful. That's why I use these matrices so often. Very useful. The ADA says to screen all individuals over 45 every blank years. 3. Diabetes. Protein. Lifelong. October. PCOS because of the O. November. Oh, December is dyslipidemia. What's November? Oh, no, it's impaired glucose tolerance. Targets. Liver. Autoimmune. Cortisol. Protease. All right, measurable goal for management of diabetes. What do we want our fasting glucose to be? 70 to 100? 130. Come on. High-risk ethnic groups, history of gestational. Stimulated by insulin and elevated what? What elevated what would stimulate glycogenesis? Glucose? Hypertension greater than 130 over 85. Fasting blood sugar, what's diabetic? 100 to 125. Insulin deficiency. L cells. Childhood. Fatty acids, which are turned into ketone bodies. Blood pressure. Yeah. If it's, did I say that already? 130/85 for metabolic syndrome, 130 over 80 for diabetes. So we just want to knock 5 off that diastolic number, of course. What inhibits insulin? Somatostatin and something else. What would catecholamines would do it? 90 to 95. 6 more new ones. Partial defect. What's pre-diabetic for an A1C? 5.7 to 6.4. What inhibits glucagon? What would say, hey, we don't need any more sugar, we have enough? Why is fasting not in stimulating? I can't think of a single thing. Like hyperglycemia, insulin. Yeah, paracrine insulin. glucose, somatostatin. Yeah, we need to know that somatostatin. It's not helpful that I covered all three for that. Look for family history of other autoimmune conditions besides diabetes, like vitiligo. Glycosuria begins with serum glucose 180. 4 times a day, you get the implantable thing. This is just fasting blood glucose. Test at 24 weeks. Ketone bodies. Pre-diabetic for OGTT. (140 to 200). Postprandial glucose less than what for management of diabetes? Bro, would it be high? 100? 180. Okay, that makes sense. Yeah, we got to give some time for insulin or whatever med we're on to work. Low HDL men and women. Men less than 40, women less than 50. So we want men to be a little bit stronger there. Autosomal dominant. Destruction of beta cells. Over what is positive for GTT? 200 for gestational diabetes. What's the middle one here? OGTT. Triggers hepatic glucose and blank output. Sugar. Ketone. Oh, gestational diabetes. Just the word insulin. Insulin, just not at first. LDL less than what for measurable goals? I have no idea. 100. Okay. Counter-regulatory hormones to insulin. Name them all again. Goodnight egg. Glucagon. Norepinephrine. Epinephrine. Growth hormone. And glucocorticoids. 12. That's important. HDL greater than what? Measurable goals we should remember. Oh, I think that's the other thing. How is the other one less than 40 and this is less than 100? I don't even remember what that was for. I gotta start looking at the titles of this stuff. I don't know. Greater than 40 for HDLs. God, these numbers are killer. Years. 50. Greater than 40 in men, greater than 50 in women. Oh, maybe that is what we were looking at. To diagnose DM1, we order pancreatic antibodies, GAD65. Lactogen. 140, 150. The worst. Okay, we've seen every card. Stimulated by glucose and what? What stimulates insulin? Vagal stimulation. Yeah, that's important. Typically occurs in the second half. Hypertriglyceridemia is greater than. This is metabolic syndrome. This is what would put us in there. 150. Okay. Hmm. 40 for men, 35 for women. Polyuria. Lipid synthesis in the liver. No autoantibodies for monogenic. Catecholamines. Symptomatic and greater than 200. Yeah, that's induces gastric emptying. Glucagon. So this is screening for type 1 DM. All individuals with 2 confirmed autoantibodies. So this is that metabolic monitoring we were talking about. So children less than 5, they're a little younger, they're a little sicker, perhaps 3 to 6. And then once they're greater than 5, we just do 6 to 12. They have these two antibodies. We gotta screen them. Gluconeogenesis will present as a blank, but will have as a DM2 for LATA. But it's kind of like that mix because you have some autoantibodies. augmenters. Oh yeah, look at this connection. So somatostatin prolongs gastric emptying, slows. Growth hormone's gonna move it. All right, 74, IAA, induction of insulin resistance, stimulated by blank fasting acidosis, gluconeogenesis. Glucagon, stimulated by blank and elevated glucose, glycogenesis. Insulin, inhibited by glucagon and somatostatin. Oh, no. You're thinking of insulin. But epi still works. It probably would. Blood level is greater than 140, then we do the 3-hour test. We're missing the A, antipsychotics, steroids. We just saw that, so we'll hit that again. Fasting glucose between blank, hyperglycemia. This is metabolic syndrome. 100 to 125. 6.5 and higher. Lens. What stimulates glycogenolysis? Hey, we need sugar. Exercise, activity, catecholamines, glucagon. That's right. Can even present as DKA and DM type 1. July, BMI over 25. August, age over 45. September, sedentary lifestyle. Pentamidine. Ethnicity, Happy New Year. February, first degree relative. March, gestational diabetes. Treatment of metabolic syndrome: statin, ACE and ARB, metformin. Candidiasis, anti-insulin, cortisol. Hypertension, metabolic syndrome, vascular disease. Fasting glucose are management. I need to write these down, but just getting these numbers in my head is important. Fasting glucose between fasting 70 to 130. Monogenic diabetes, epsilon cells. Woo-hoo-hoo. Usually not obese. What stimulates gluconeogenesis? Acidosis. Growth hormone. GLP, glucagon-like peptide. T-cell mediated. What inhibits glucagon? Hey, we have enough sugar. Stop elevated glucose. Paracrine insulin. Somatostatin. Let's go. Adipose tissue. LDL less than what? 140, 100. Screening for diabetes, screening early for BMI greater than 25. Occurs in liver and kidney. We want postprandial glucose less than 180. All right, 49. Triggers hepatic glucose and glucose output. A ketone. Stop saying glucose. Glycogenolysis. Thiazide. Proglucagon. Hepatic portal. Phenytoin dilantin. Osmomolar. So that's what leads to that blurred vision. You got to connect the dots there. 24. Like Assyria. Native American. 3 of these. Glycogenesis is inhibited by glucagon and catecholamines. We'll take that. HDL greater than 40 in men. Triglycerides less than 140, 150. GABA. Liver and probably muscle. Autoantibodies. And soap. So what starts with S? Steroids. Ethnicity. That is to screen less than 45 if your BMI is over 25. Tinea pedis. (100). Proinsulin. C-peptide. Pancreatic polypeptide. 6.5 to 7. Scandinavian. Lifelong screening every 3 years. What's diabetic for fasting blood sugar? Greater than 126 and higher. So what's the 12, 24, 48 gluconeogenesis? Starts, peaks, sustains, and then 48 is done. We start breaking down muscle. Triglycerides, 150. Nice, clean number. We already named them. I'm not going to name them again. October, PCOS. November, glucose intolerance. And December is dyslipidemia. Insulin stimulated by glucose and vagal stimulation. Glucagon stimulated by protein meals, something, ketones, and cortisol. What says, hey, we need some sugar? Catecholamines. Cortisol is in starving. I mean, I should know, whatever. What inhibits glucagon? Paracrine insulin, glucose, somatostatin. Fatty acids, which are turning into ketone bodies. Hemoglobin A1C, what is pre-diabetic? 5.7 to 6.4. Matt, all right, we're 17 away. Fasting glucose, 70. This is fasting, 70 to 130. Ketones. Low HDL, we want men. No, this is not. This is low HDL. This is for metabolic syndrome. I think this is 40, 50. Yeah, that's because we wanted higher than that. So 40, 50, men, women is what you want to remember. Blood pressure is 130 over 80 for management of diabetes. Hypertriglyceridemia is greater than 150. Love that number. Over blank is so 150. 50 times 3. Over blank is positive here. 200 for OGTT for gestational diabetes. Epsilon induces gastric emptying. Delta cells will prolong it. Stimulated by blank fasting, gluconeogenesis. Glycogen. Glucagon. That's what I meant. You know what I meant. You know what I meant, right? GAD 65. 50 in women for HDL. Ketone. LDL less than what? 100. Management of diabetes. Keep that LDL under 100. Potential obesity measured by waist circumference. 40 in men, 35 for women. Ketone. That's what happens in hypoglycemia. Cortisol. 180. Increased BMI over 25, age over 45, sedentary lifestyle. Acidosis. 150. 40. Catecholamines. Steroids. Inhibited by glucagon and catecholamines, epi. Fasting glucose 72, 130. Insulin is stimulated by glucose and what else? Vagal stimulation. That was only what, an hour and a half, hour, 40 minutes? And we hit 709 cards. I need a break. I'm going to grab some lunch. I do want to get through at least treatment, because most of that is on one card. I'm actually pretty excited for that one. So I think we'll pause here.